Good morning, everybody, or afternoon. I think it's right in the middle of the day for most everyone, and glad to be here. Uh, uh, it's actually quite quite an honor to be here for Cancer Patient Lab information exchange. I see this as actually a leading edge, quite leading edge forum for bringing together ideas and this issue, uh, it gets pretty challenging to understand the big picture and to piece everything together. And there's a lot of different perspectives, a lot of different points of view. And so what I'm going to do is present the way that it looks to me to have a coherent, cohesive understanding of what we're looking at and what we're attempting to do in managing cancer. And that this is the field of molecular integrative oncology, the in addition to conventional oncology treatment, not instead of. And uh, uh, based on what I found many years ago, and it was published in a landmark journal special issue, open access issue of Seminars in Cancer Biology, is a good place to start to look at the underlying foundational concepts of using a broad spectrum of therapeutic agents, and in those including natural health products as well as repurposed pharmaceuticals. Seminars in Cancer Biology, very high impact journal, generally not open access. And at the end of 2015, this series of articles after Dr. Leroy Lowe had a project of 300 cancer researchers and oncology doctors who divided themselves up into 10 different groups, each looking at one of the hallmarks at the time. And the 3-year project was to synthesize information about how to control the progression of cancer by intervening at each one of these hallmarks, and came to the conclusion that it's a evidence supported approach to provide a broad spectrum of natural products and repurposed pharmaceuticals. And so I'll point you to that open access journal because it really is a good foundation for moving forward. The molecular integrative oncology, I think of it as at the one of the emerging edges of synthesizing the knowledge that we have, and that this is primarily based on looking at the preclinical trial data. So we don't have clinical trial data for this by definition.
Just started.
Preclinical trial
Started.
Oh, I thought it started like an hour ago. Okay, I'm gonna go.
All right, we're gonna
Getting back to the,
navigate that sound.
I'm going.
I'll handle
Not
it.
sure how that gets done. Okay. All right, so the field is molecular integrative oncology. Integrative oncology has a very broad range of options, and we're narrowing the focus to the molecular biology of integrative oncology. And here is that article, that special issue for reference, a 3-year project. The project is called Getting to Know Cancer, and they were evaluating the hallmarks and control of cancer using additional available therapeutic agents. And so what is it we're actually looking at, and what are the challenges? the core, from my perspective, is looking at the tumor microenvironment, and it's often neglected to emphasize all the characteristics of the tumor microenvironment. And that includes the cells and molecules in the tumor microenvironment, all of the cells and all of the molecules in the tumor microenvironment. We have the data that we know about of the cells and the molecules in the tumor microenvironment is readily available. Doesn't mean it's easily available. And the core seed that makes sense to me to plant is the concept of always looking at either pro-cancer or anti-cancer activity, pro-cancer or anti-cancer directionality. That term, pro-cancer or anti-cancer directionality, can be applied to all of the information we have about the cells and the molecules in the tumor microenvironment. So, excuse me, seeing all the components in the tumor microenvironment through that lens of pro-cancer, anti-cancer directionality places a perspective for searching as well as understanding the information that's in the literature. And that provides a structural framework for making choices and decisions about therapeutic agents. So understanding this core concept, it's, for me, it's a important privilege in planting that seed here, because I think all of the additional information that we're pursuing comes back to that line. We're maintaining that line of understanding throughout the literature and using it and applying it regarding all the cells in the tumor microenvironment and all the molecules that we're discussing and reviewing. When you look at the tumor microenvironment, oftentimes it's presented in ways that are quite confusing, very complex. And when we look at it from a high level overview, there's really four main categories that virtually everything in the literature falls in these four main categories of cells: the cancer cells and cancer stem cells, the vascular cells, the immune cells, large category, many different types, and the stromal cells, which may be relatively neglected in the attention and are fundamentally relevant in the development of tumor, especially tumor. Once a tumor population, that community of cells proceeds and grows large enough that you can see it on imagery. So if we take a bigger expansion of that information, the vascular cells, by the time a cancer cell is growing, dividing, accumulating, growing, dividing, accumulating, a group of cells, that the center of that mass develops a lower oxygenation, hypoxia. And the cancer cells, like healthy cells, are always attempting to survive. They produce molecules to induce nearby blood vessels to either turn and grow to supply more oxygen, or to newly grow to supply more oxygen. That vascularization of the tumor is not normal, healthy expression of vascular cells, and it is still vascular cells, endothelial cells, and pericytes that are the tumor vasculature that are relevant. And the immune cells, there are many different types. The cancer cells producing immune messenger molecules to recruit, induce, even molecularly kidnap certain components of the immune system that are generally associated with wound healing and anti-inflammation. And there are the main cell types, the lymphoid cells with multiple subtypes, and the myeloid cells with multiple subtypes, and their interactions with each other. And then importantly as well, the stromal cells, which are structural support cells and maintenance cells. And that by definition, a tumor that exists with the cancer cells and cancer stem cells, let's say, at the center of our focus, that it's important to expand that focus, that awareness, to include all of these cells because they are mutually reinforcing. The cancer cells and cancer stem cells clearly at the center of our attention, the center of our focus. And because the cancer cells are producing molecules that induce or recruit, or could even be thought of as coerce and kidnap other cells that are good, desirable, necessary, normal, healthy cells in other circumstances and in other locations, now are forced into the service of supporting and maintaining and camouflaging the cancer cells. And that means that we have to consider all of these cells concurrently and take an integrative, networked perspective of how to manage these multiple cell types concurrently to control the progression of the cancer, in addition to whatever is the conventional treatment, targeted treatment, immune targeted treatment, conventional cytotoxic therapy, radiotherapy, or other ablation therapies, all of those in addition to this preclinical trial data access to make therapeutic choices about products that are already available, natural products and repurposed pharmaceuticals. So if you think about each cell type, the cancer cells and cancer stem cells, the tumor vascular cells, the various immune system cells, and the stromal cells, principally focused on the cancer-associated fibroblasts, but also mesenchymal stem cells, that all of them have molecular pathway activities that we have some idea or even a very large number of, or large understanding of many pathways. Various cell types, we have greater or lesser understanding of the relevant pathways in the pro-cancer direction. So by definition, the tumor microenvironment is the pro-cancer environment. And we're looking at what are the expressions of the molecular pathways in each of those cell types. The pro-cancer molecular pathway activity in the pro-cancer molecular interactions among the multiple sites along those molecular pathways. We have a lot of that information. We have it in many cancer cell types, and we have it with many therapeutic agents, the response to those, the use of therapeutic agents in counteracting the pro-cancer molecular interactions in an anti-cancer molecular direction. And that understanding guides this methodology as we go forward. And that if you think more deeply, that the pro-cancer molecular pathway activities at these molecular interactions are generally characterized as either pro-cancer upregulation activation or pro-cancer downregulation inhibition. And that our approach then is to either use counteracting molecules as anti-cancer downregulation inhibition or anti-cancer upregulation activation. So we're looking first to identify the pro-cancer molecular orientation and identify where are there data supporting anti-cancer molecular intervention, either at that particular molecular interaction or perhaps cross-stream or downstream, excuse me, or even upstream to that. And we have significant data about those options, about those possibilities. And so the progression of cells to pathways to organelles to molecular interactions, importantly, whether those molecular interactions are the wild type or altered, and the pro-cancer, anti-cancer directionality of them, looking to drive and direct therapeutic interventions to counteract the pro-cancer molecular pathway activity among this group of cells in the tumor microenvironment. And when I'm talking with people who have come seeking these personalized treatment plans and their families, that I use some terminology that's quite non-scientific to illustrate some of the concepts. And that when we talk about all of these cells in the tumor microenvironment and the molecules inside them and between them, I use the imagery of cellular meetups and molecular meetups, that the cells are talking to each other using molecules. Sometimes the cells are directly in contact with each other, direct contact. Other times the cells are producing molecules that affect the other cells. Other times nearby. Other times they're producing molecules that affect cells far away. So paracrine signaling, autocrine signaling, where they're producing molecules that affect themselves, or far away endocrine signaling. So we're talking about molecules that are released to affect other cells, and the affecting of those other cells often causes those molecules to be released that affect the cells in a feed forward cycle, a self-reinforcing cycle, a vicious cycle, if you will. And that this information gives us opportunities to look at where are there molecular pathway activities that can be intervened, in which we can apply molecules for anti-cancer molecular effects using the preclinical trial data to make educated or rational decisions about applying the therapeutic interventions targeting multiple molecular sites simultaneously, concurrently. And I have a large number of slides that I can move to in response to various questions. But the general overview is we see that there are, in virtually every tumor type, whether it's solid tumor, carcinomas, sarcomas, or whether it's hematological malignancies, that there are multiple molecular pathway activities and multiple molecular interactions along these pathway activities that show pro-cancer molecular effect, pro-cancer molecular expression, and that there are data showing the anti-cancer counteracting anti-cancer molecular effect of multiple natural products, repurposed non-oncology pharmaceuticals, repurposed conventional oncology pharmaceuticals, including targeted agents and immunological targeted agents, and that these can be considered in a bigger picture as we move along and see that we're inherently targeting and managing molecular networks among these cells and within these cells, that this opens a bigger perspective of targeting with network pharmacology, a broad spectrum of therapeutic, concurrent, natural products, repurposed pharmaceuticals to control the progression of the cancer by controlling signaling networks in cancer cells and cancer stem cells and tumor vasculature and immune system cells and the stromal cells. So to recap, we're looking at the cells in the tumor microenvironment, and there are numerous types of them, 4 main categories. You can easily identify at least 20 different cell types, and the molecular pathways within those cell types expressing, including through the organelles in those cell types, and the various molecular interactions that are either normal wild type or altered, including mutated interactions through the lens of the pro-cancer, anti-cancer directionality, and that guiding the selection of therapeutic interventions, including the preclinical trial data, the in vitro and in vivo human and animal cancer cells in test tubes and in animals of the therapeutic options, including those that are already on the market, the natural products and repurposed pharmaceuticals. So I'm going to stop there because there are any one of these aspects we can go very deeply into discussion. I've got other slides for supporting that kind of exploration and discussion. So I'll leave it there and open it to any questions to get things moving.
Okay, let's open it up to questions, and go ahead and unmute your mic if you have a question. You know, while we're waiting, maybe could you talk a little bit about?
I have a question.
Okay.
Sorry.
Who's that?
My name's John, and I was just wondering about what you're using in terms of inputs to identify these sort of cells. I have pleomorphic liposarcoma. One of the things that I've had done is the Boston gene, next generation sequencing. And they have a TME section on the report, and it was basically like, well, we don't really have a lot of data. And so they have RNA sequencing files. I actually have those FASTQ files. And I have I spoke with a researcher who was talking about how other NGS teams, will focus more on the TME, and he was talking about that to say it's highly fibrotic might mean that's good or bad, it's that sort of thing. But the takeaway that I kind of got was, at least from that particular report, it was kind of just saying, well, we identified some cells in the TME, but we don't really know what to tell you. And so I guess in terms of this highly targeted makes sense to me, saying here's where you look at all of these different potential interactions and behaviors and how they might interact. How do you get the information about what cells you might have in a given TME?
Great question. What I'm presenting here is a framework for pursuing that information. Oftentimes, we have very little of that for a specific case or a specific either biopsy or pathology specimen. That there are now there's more interest looking at the cell types as spatial analysis, looking at what cells are located in what positions in the tumor. But oftentimes we don't have the data that you'd like to see. What I do is look in the literature for what are the characteristics associated with that tumor type and the likelihood of greater in sarcomas, for instance, the greater activity for fibrotic activity or other extracellular matrix development in the tumor microenvironment, and what are the cytokines and chemokines, the immune messenger molecules or growth factors that are generally associated with those activities in that tumor type, and aim for that. We're in very early days, and the protocols, even the leading edge protocols, the ones with the most sophistication currently, I think are likely to be seen as quite crude first efforts or early efforts compared to where we'll be in a short period. I think in the next several years, we're going to have much more advanced understanding. And then it comes down to what tools are we actually willing and able to apply, what therapeutic molecules. And I think that the molecules, the natural products which are already on the market, they're a reasonable set of choices, and it's still very crude. We're limited to the dosage forms that are available in retail, and that's not optimal. And then the repurposed non-oncology drugs, there are substantial data about using already available repurposed pharmaceuticals targeting fibrosis, targeting the inflammatory activities that are occurring in the tumor microenvironment. And in those, we're very often still quite limited to dosage forms that are already available. We can dose them in off-label dosing schedules, and I generally strongly start everything very low, at its lowest dosage increment or even lower, and proceed in a very gentle dosage escalation among all of the agents that are being therapeutically applied. And the underlying fundamental criteria for implementation is the treatment plan is designed and intended to always be comfortably well tolerated. That means having a method for closely tracking cause and effect. So because the simple conclusion is, if the person isn't tolerating the treatment plan comfortably, then they will be struggling with it and they won't be able to take it. And if they can't take it, it can't have any benefit. And so that fundamental requirement of developing a treatment plan scientifically really doesn't provide value unless it can be well tolerated and implemented in a manner that remains comfortably well tolerated in order to be able to administer for extended duration. And extended duration, I think, is well defined as, I think, 3-month increments. And at the end because commonly in the oncology evaluations, after 3 months, there's some follow-up imagery or some other evaluation, the oncology team, and then a decision can be made about the next 3 months of therapy, whether it's a change in conventional oncology treatment or no conventional oncology treatment, or modification of the the cancer wellness plan, the implementation based on the circumstances. So based on the indications at these intervals, and many people can implement for 3 months and another 3 months and another 3 months. The use of the repurposed pharmaceuticals, I think, can have very significant impact on the tumor microenvironment, the stroma, the stromal cells, and the immune cells. I hope that gave an outline for answering your question. We don't have the specific answer of, well, in this tumor with this characterization, use these drugs specifically. We're not there yet. I think using the spatial analysis and identifying in your particular tumor type when a biopsy or a surgical resection occurs, and looking at the spatial location as well as the molecular profiling, the various omics options that are available, can give some prioritization to the therapeutic protocols, to aiming more in this direction versus that direction in the treatment plan.
Okay. We have a question in the,
John, did that get to where you wanted?
Yeah, I appreciate that. You actually kind of pre-answered the other question I had, which was the signal or feedback loop in terms of if it's working. And it sounds like slotting into the usual surveillance scans and that sort of stuff. I'm wondering if we'll have in future opportunities along the like liquid biopsies line where you're kind of able to see, or the cfDNA, that kind of approaches to see if it's active without having to, just do a CT that's spread out at that cadence.
Yeah, I think the liquid biopsies are quite valuable, quite important.
okay, did that answer your question, John?
Yes, thank you.
Okay, we have a question in the chat. It says performing single cell RNA sequencing on both malignant and benign or normal tissue provides more opportunities to understand the underlying pathology and identify potential treatments. So you have any comments on that, Dr. LaValley?
Sure. So the more omics, the better, from my point of view. So when my patients have come to me, or other doctors' patients, that they will generally have a pathology document specifying their specific cellular diagnosis with some or another markers that validate that diagnosis. And then some people also have additional omics, genomics, transcriptomics, proteomics, sometimes metabolomics. And those can be helpful in directing the search for what therapeutic agents are relevant and rational for counteracting those. Those are generally focused on the cancer cell, sometimes also the cancer stem cells. That guidance can provide better focus for therapeutic intervention, treatment plan development, but that we're still, again, in these early days. And what I'm proposing here is a framework for encompassing all of the therapeutic perspectives, all the therapeutic options, by that directionality, that pro-cancer, anti-cancer directionality, looking at all of the cancer types, and then, all of the cell types, and then using what data we have within each of those. Here, if you're talking about the transcriptomic, the RNA data, or other omics data, that can steer what we're aiming at and what we're aiming with.
Okay. Any other questions? Well,
It said,
of course,
here was a note, have they resumed recording for Brad's notes?
yes, it's recording.
Okay.
Okay, we have another new message. What are some of the harms in performing therapeutic interventions with minimal, non-comprehensive molecular insights?
Well, there's potential serious adverse effects because we don't have the data about the range of adverse outcomes. Clinical trials, the gold standard, that boundary between conventional oncology and the preclinical trial of the molecular integrative oncology. The clinical trials are the gold standard. I think of it as the top of the data mountain, the best data we have, and that data, it gives us the likelihood of benefit and the likelihood of risk. And usually that risk is stratified when you look at the data about the risk of one or another, or a therapeutic protocol, conventional oncology protocol, often along the lines of greater than or 1 to 30% chance of this, less than 1% chance of that, or some other form of stratification. And because we don't have that data, because of the lack of clinical trials, we have to acknowledge that there exists the possibility of serious adverse consequences that could cause serious illness requiring hospitalization, or could even be fatal. And that acknowledgement means we need to manage safety and tolerance very closely. And that's why start low and increase slowly, with very closely tracking when you take this, here's what we see, cause and effect, cause and effect. And there's a methodology for doing that. I think it's probably beyond the scope of our discussion today, that managing that risk means acknowledging the unknown and managing it because it's unknown. Clinical trials are going to make this much better, but up till now, you haven't had any clinical trials that are relevant. This group that put this a special issue together, getting to know cancer, that group went on to become to have a 2.0 version of itself, to develop potentially clinical trials. And I got invited into that organization, and it's called broadspec.org. I think it has become somewhat dormant at the moment. It looks like it may reactivate to do clinical trials in this methodology of using a broad spectrum of therapeutic agents targeting these multiple molecular vulnerabilities in network pharmacology, and implemented in a manner that remains comfortably well tolerated.
Okay. Any other questions from our group?
Cindy's got a hand up.
Someone's got a hand up. Who's that?
I have a hand up, Cindy
Okay.
Ness.
Okay.
Yes, hi, thank you for such a wonderful talk. It feels like it's really the cutting edge of what we should all be thinking about. And it's much more dynamic than I think what the conversation sounds like inside standard of care, institutions. You talk about like what we're doing, and I assume that a lot of what you're talking about is outside of, let's say, the big institutions. I guess my question is, What, if any of this tumor microenvironment emphasis, certainly there's research on it, but clinically, what, if any of this is going on inside of, in standard of care institutions? And if it's limited, could you give us your sense of why that is? I'm sorry, my video isn't on. For some reason, it's not turning on.
Sure. So I'm not involved with any big institutions, so I can't accurately speak to what the current approach in any particular institution is. I know that there is much more emphasis in discussion about tumor microenvironment. So maybe this is helpful, that there's an opportunity here to discuss the evolution of how the tumors are occurring. So a healthy cell, because I think it can drive some of the discussion that I think you're pointing to. Healthy cells have some sort of adverse changes that then they become malignant, that called transform to become malignant cells, and that there are two characteristics, they're hallmark characteristics that I think from which the other characteristics can be derived. That the growing signaling, so one molecular interaction signaling the next, that growing signaling, those growing signaling pathways are turned on, they're turned up, and the stop growing signaling pathways are turned off. They don't have the mechanism to turn off the growing signaling. And that causes the cell to grow. It reaches a specific critical size, now divides and accumulates, grow, divide, accumulates. And that the adverse interaction from various stimulation, various environmental factors triggering is quite different among various cells, and that most of the time the cell that now has become transformed is by itself, and it's not necessary. We're talking about at the beginning, at the initiation, and that it can put molecules on the margin of the cell, on the membrane, that identify it as malignant, and the anti-cancer immune system comes along and very quickly eliminates that cell. Or the cell becomes so dysfunctional that it then triggers automatic programmed cell death, apoptosis, automatic program recycling, I often call it to people when I'm talking to lay persons. And that once in a while, the transformed cell is nearby or next to a stromal cell, a fibroblast. And the fibroblasts, I think, are generally not well described or emphasized. And now what are they doing? Those cells are producing molecules that are essentially attempting to help whatever cell they're next to be better. And so the structural and maintenance support that's coming from fibroblasts, which are ubiquitous in all our organs, that they're now receiving signals from the malignant cell, and they're saying, okay, how can I help you? How do I make you better? How do I make you stronger? How do I protect you? How do I support and maintain? And that is a big issue with regard to focusing on tumor microenvironment. The chemokines and cytokine, that the immune messenger molecules and growth factor molecules, the molecules that are exchanged between these and among the cells in the tumor microenvironment, we have some excellent targeted agents already available, some for cancer, others for other diseases, including, or other conditions, fibrotic conditions, immunological dysfunction, or people who have inflammatory conditions. And those molecules could be used in orders of magnitude lower, potentially much lower dosing in off-label dosing. I think of it as mini dosing or even micro dosing when you look at the tumor the immune system cells. So using molecules that are already on the market in much lower doses that are in off-label dosing to target the changes in the extracellular matrix, the tumor microenvironment, development of fibrotic tissue, in addition to targeting the molecular pathways in the cancer cells and cancer stem cells.
I'm so sorry. May I interrupt? First of all, I'm not a physician, so that's really interesting to me, and I'm learning, and I'm always trying to absorb. In my practice, which is a psychology practice, I have 3 patients that, and I see a lot of folks who have a cancer diagnosis who need something more than what they're finding in standard of care, institutions. I guess what I'm trying to get at here is, how does then the patient outside of standard of care institutions access this kind of thinking, this kind of approach to their own treatment if they, in a sense, want to go as an independent? And I mean, what would that look like? I mean, I'm always interested in how all these good ideas work sort of on the ground. So maybe you could tell me, so what does the application look like if someone says, wow, I think this is really right. This is what I need. Now what?
So the people with a cancer diagnosis or their families will reach out to us, and I collaborate with local integrative medicine physicians throughout the US and Canada, sometimes overseas in Europe or Australia or New Zealand, about the doctors receiving a treatment plan for their particular patient, and then a method for implementing that treatment plan so that it fits right into their local integrative medicine physician's workflow. Because the integrative medicine physicians are generally accustomed to using natural products and off-label pharmaceuticals in addition to conventional care, and that they're familiar with that. I will have a collaborative relationship with them, and they can receive a set of treatment plan recommendations, review it, revise it in whichever manner they choose, and then administer it. And we follow up very quickly with a training about how that doctor's selected treatment plan can be efficiently implemented. So we stay very focused on only that implementation of what that doctor has administered, authorized, and is being implemented. That's a practical way of allowing people access where they live, because this information takes quite some time to assimilate and to put into a comprehensive treatment plan for application, for implementation.
Thank you.
Thanks. So we have a question in the chat. It's actually the question I was going to ask you about, and it's about resistance. And the question is there anything to prevent cells from becoming resistant to therapeutic interventions, especially microdosing? Do you have any comments on that?
Yes, actually, I do. Let me go here. Just one second. So we're aiming at all of the hallmarks. And there are some natural products and some repurposed pharmaceuticals that can target the hallmarks. and that the methodology rationale is target the molecular networks in all of these cells. And what is displayed here is the Kyoto Encyclopedia of Genes and Genomes, the big picture pathways in cancer map, and the hallmarks or characteristics associated in the cancer cell. So this is not the whole tumor microenvironment. This is the cancer cell, the boundaries of the cancer cell, including major pathways, and how we can emphasize targeting pathways for particular characteristics. And that when we looked at then the next major resource, the Pan-Cancer Atlas, and the main signaling pathways that were published in the Pan-Cancer Atlas, I think about 8 years ago, including what are called the top 10, what I call the top 10, that is defined as the flagship paper, oncogenic signaling pathways in cancer, that those 10 major pathways demonstrating actionable alterations. And so that's an important aspect of these pathways, is the emphasis that each one of the molecular interactions identified in this particular perspective of these 10 pathways, each one is actionable, potentially therapeutically actionable because of the alterations, in order for it to focus on targeted and combination therapies. And here's the outline of that map. And then when you fill it, it's still quite overwhelming. So to simplify it, an animation made it easier. I animated it so I could understand better. Here's an example of an important pathway cascading molecular signaling. Each one of these molecular targets potentially actionable alteration that results in cell proliferation, grow, divide, accumulate, grow, divide, accumulate, cell survival, and protein production. And each one of these pathways associated with particular activities. If we fast forward among all of them, through all of them, importantly, they're all connected. And that's where the issue of managing resistance is, I think, presents a great opportunity. That when we have a particular targeted agent that's targeting a specific molecular address, a specific molecular site. Oops, I'm not sharing, sorry.
Yeah, no, you're not sharing anymore, but we've only got 2 minutes left, and we do have one last question.
So let me find, I'm sorry, because the natural products and repurposed pharmaceuticals target multiple molecular sites simultaneously as the cells are attempting to compensate through that compensatory signaling, we're meeting their attempts to compensate with a greater anti-cancer intervention. And the concept is to decrease the capacity of the cells to compensate, to use that compensatory signaling to adapt to the adverse intervention. And so there are data showing natural products and repurposed pharmaceuticals can have enhanced effects to increase the ability of the chemotherapy or targeted agents to target and eliminate the cancer cells, enhance chemosensitivity, and decrease chemoresistance.
Okay.
I'm sorry, I forgot that I wasn't sharing.
Yeah. Well, we're at 10 o'clock, and I have to run here. I know there is another question in the chat, and guess if you can answer it in 1 minute or so, It's
what
what
is that?
it's-
I don't see it.
to what extent the epigenetics and ethnicity influence the microenvironment of cellular and cancer dynamics?
I don't know any information about ethnicity. I do know that epigenetics can have significant impact. The challenge is how to navigate that and manage that. And I think diet, stress management, other environmental exposures, as well as the molecular therapeutic interventions have capacity to have beneficial effect.
Okay, last question. How do people get a hold of you if they want to follow up?
Through our website, you can, it's LaValley MD protocols.com.
Okay. All right. Thank you very much for being here. I'm going to go ahead and conclude the recording.